So I really don't need to tell this group what the cause of emphysema is and the pathophysiology of it. But again, overinflated segments, non-functional, they compress the functional lung, which is the important part, and why the surgical removal of that works. Emphysema also leads to the increased ventilatory drive, auto PEEP, and of course diaphragmatic flattening, which decrease inspiratory efficiency. So again, the idea of lung volume reduction surgery is to remove the hyperinflated lung parenchyma, restore more normal breathing mechanics, improve exercise tolerance, and therefore improve your symptoms. Again, the history, as we've heard, dates back a long time. The first surgical lung volume reductions were done in the early 50s, and they, of course, were fraught with high morbidity and mortality. Dr. Joel Cooper, who's really one of the fathers of modern lung transplantation and surgery for lung failure, improved the techniques quite a bit in the early 90s, and again, that led to the NET trial, which showed improved outcomes, increased exercise tolerance compared to medical therapy alone. And I'll go over that a little bit more specifically a little bit later. So the key for surgical lung volume reduction, again, is patient selection. Obviously, the patient needs to have end-stage emphysema, decrease FEV1 to FVC ratios, decrease FEV1s, hyperinflation, diaphragmatic flattening, in worsening symptoms despite maximal medical therapy. The best diagnostic tools for this are CT scans and ventilation perfusion scans. What we'd like to see is sort of specific areas where there's a lot of bullous disease compared to the more normal lung. We see VQ mismatches, and of course it's important that we rule out other pathologies. So of course what we found is the best outcomes occur with heterogeneous distributions of the emphysema, as seen here in the upper lobe predominance. And again, the NET trial showed us, and I'll show you in more detail, that upper lobe predominance clearly does better. So again, the best results surgically came with heterogeneous distributions, predominantly in the upper lobe. So this would be sort of our prize patient right here. So again, to determine who would be an acceptable surgical risk is really no different for these patients for any other surgical patient or end-stage lung patient, but they'd have to have an acceptable cardiac risk, the ability to comply with rigorous pre- and post-operative pulmonary rehab, which we've heard a lot about this morning. Obviously, smoking cessation is important for this. And again, all of these other parameters, I don't think because of time constraints we should go over, but again, all the basic things that we look for in our surgical patients. The techniques for doing this are sort of twofold. We typically, if we're going to do bilateral, early on it was always done through a midline sternotomy. That allowed access to both hemithoraces, so we can take care of both lungs at the same setting. Through the sternotomy, you can inspect both lungs completely. You can correlate with the radiographic findings. You can mobilize the lung, divide the pulmonary ligament, and then staple remove the diseased segments. So our stapling devices have gotten much better over the years. As our non-surgical colleague just told you, one of the problems with the NET trial was all of these patients had pneumothoraces and prolonged air leaks. 50% ended up with significantly prolonged air leaks. Nowadays, our stapling devices have gotten better, both the staples themselves. We now have many different depths of staples and thicknesses. In addition, we have different buttressing devices, either bovine pericardium or PTFE, which allows a proper seal on the lung that we cut, and therefore that cuts down on the post-operative air leak. So that's really helped out quite a bit. So again, through a sternotomy, you can access, this is the left pleural, or right pleural space, and additionally, you can get the left pleural space and take care of both sides with one incision. A key for surgery is you don't want to resect too much. You just want to take out the non-viable segments. We also now have a lot of topical sealants, which are also quite useful in taking care of the air leaks post-operatively. Other modalities used over the years were pleural tents, where we can mobilize part of the parietal pleura and then either suture it or just lay it over the area where we've stapled, and that also will help seal any micro air leaks. One lesson we learned early on after the NET trial was post-operatively we don't put the patient's chest tubes onto suction. That tended to make the leaks worse, especially, remember, you're dealing with lungs that, well, none of it is normal. You know, if you suck on it and it gets caught on the more normal lung, you can destroy that lung and cause the air leak to get worse. Early extubation is crucial. That restores the normal breathing mechanics, prevents positive pressure, and that also cuts down on the air leak. And then, of course, aggressive pulmonary toilet. These pictures are just showing these pleural tents we can use to seal over the stapled areas. With the progression of thoracoscopic techniques in surgery, we started to do more and more of these procedures rather than through a sternotomy thoracoscopically. The main benefit of that is, of course, it's much smaller incisions. As our instrumentation has gotten better, it's made this much easier. The downside of this is just that you can't address both sides simultaneously. So you can do this one of two ways. You can pick the worst side, take care of that, send the patient home, bring them back at a later date and do the other side, or we can do them both simultaneously. It just requires repositioning of the patient, which makes it a little more cumbersome for both the surgeon and the anesthesiologist, but it's certainly something we do fairly often. And again, through the thoracoscope, we can accomplish the same thing. These staplers are obviously a little bit longer than the ones we use when we're under direct vision, but they work quite well. And we use these instruments nowadays, even when we have an open incision. They're just, again, slimmer and more aerodynamic and much easier to handle. When we look at patients that have had lung volume reduction through either a sternotomy or through a thoracoscopic approach, there are some differences. They have comparable morbidity and mortality. However, there is an increased length of stay if you do it through a sternotomy, which was statistically significant. And also the cost and return to independent living is better when you do it through the thoracoscopic approach. So I think nowadays, I don't have exact numbers, but I would say most people are trying to do it through a thoracoscope rather than through a midline sternotomy. And again, as we talked about, prolonged air leak was the most common complication we saw, and we still see. Of the 1,000 some odd patients that were evaluated in the NET trial, about 50% of them ended up having a prolonged air leak. And again, nowadays, remember the NET trial came out in 2002 or 3, so we're 15 years down the road. I think technically we've gotten better. We have better instrumentation and other modalities. So prolonged air leak that kept the patients in the hospital for 3 or 4 weeks at a time is really something that I think if the NET trial was repeated today, we'd probably see it in the 10 or 12% range rather than the 50% range. These are some of the topical sealants we have that really help out. And we use these pretty routinely, even on just regular cases, because they really do work quite well. So again, it's important to understand these are palliative surgeries. The NET trial as a whole showed no overall survival advantage. As somebody else alluded to, there are subsets that do show survival advantage, and I'll show that here in a moment. Again, you have improved FEV1, respiratory muscle function, exercise tolerance, the 6-minute walk test increase, their dyspnea increases, and therefore it's a quality of life thing. And most of those improvements are pretty durable and are seen out to 1 year. By 5 years, a lot of these patients feel like they've returned to their baseline. Again, we've talked about the air leak. 20% of the patients in the NET trial did show some cardiac morbidity, being most fairly easy to treat. And again, there is some mortality operating on these sick patients.